So I think we're going to kick off. I will admit people, so if I get distracted and I go to admit people, please excuse me. But yeah, I think it's lunch and learn. So we are going with the lunch bit. Let me admit this person. Admit. Great. Welcome everyone to the Joint Dynamics Evolve Lunch and Learn series. We're really excited to have you here. This is the third in the series, and we've got lots more planned as well. Today I've got the very lovely Jess with us, women's health physiotherapist at Joint Dynamics Evolve. We're going to be talking all things postnatal. Jess has a real passion for this area in women's health, so we're really excited to see the education she's able to provide to us today. Jess is a qualified and very experienced physiotherapist in the area of women's health. She's board registered both here in Hong Kong and in the UK. But I would highlight this session and the recording by saying she's not your women's health physiotherapist. So if you do, the information she's going to talk to us about today is going to be generalised, all backed by evidence and scientifically informed, but generalised. So if you have any particular questions, we do highly recommend that you seek your own GP, OB/GYN or physiotherapist's advice on anything very, very specific. But this is part of our mission to help educate and bring the community together around these really exciting times. Do that. Excellent. Jess, welcome.
Thanks for having me. Excited.
Jess, we're going to kick right in because everyone's on their lunch break or running between activities. We want to talk postnatal. We want to talk baby. Baby has arrived in whatever process baby arrived by. Let's go from home from hospital. What are we expecting in these first few weeks?
So obviously a big important time, massive transition from where, especially when you are going from hospital to home. Obviously dependent on the birth that you have and the location, in terms of the hospital type, you might stay in hospital for a day or two, and then equally it might be longer than that, sort of 4 or 5 days. But what I always say is go, if you're in a position to go home when you feel, make sure you feel ready to go home, basically, because it can be quite a daunting idea going from being in that protected hospital environment to then kind of out on your own at home. In the first few days though, we always expect that you're going to feel quite fatigued, especially if you've had a C-section, just because obviously it's major abdominal surgery. You will have a wound, you will have a scar, you will have stitching. So that can come with its challenges. For a C-section mum, we know that you will have to take it even more steady, in particular, just because of that scar. So making sure you're resting as much as possible, asking for help when it is needed, and just taking those first few days really, really easy. I think it's quite difficult because as women we want to crack on and do as much as possible and kind of let normal life resume, but your body's gone through a huge amount during a C-section, so it will be about just taking it easy and learning how to pace. With a vaginal delivery, you will still feel equally as tired and as exhausted, especially if you have had a longer labor, or if you've had a birth that required instruments. So again, rest is really, really important at this point in time. But definitely with both C-section and vaginal delivery, in those first few days to weeks, you can absolutely start getting out, moving, walking, practicing getting in and out of bed. If you've seen a physio, they can give you some little exercises to complete in sort of weeks 0 to 6. So in that kind of fragile time, there's lots that you can do if you've had a bit of guidance. But I think in those first few days to weeks, when you're doing that transition from hospital to home, it's really understanding the difference between pacing, resting and recovery, really.
again, having someone else to help, I think, is a key as well, right?
Yeah, if you're lucky that, yes, if you've got that help there,
Then
take advantage of it, because you're never going to get this time back, really, where you can kind of try and rest.
yeah. Jess, obviously, we are all hugely, we're all waiting for the 6-week OBGYN checkup.
Yeah.
Can you talk us through what that checkup with that doctor is and what it is not?
Absolutely. So every mum should receive a OBGYN check at around 6, and sometimes it can be 8 weeks, depending on various different things. But this check is purely a medical check for both you and baby. So it's definitely out of my scope of practice as a physio, but as far as I'm aware, the doctor's going to be checking through your general health. They may do an examination for any particular reason, but they'll be mainly just checking in on you and your baby's health and making sure that kind of feeding is okay, just asking kind of if there's any major issues. But the emphasis here is that it's a medical check. What they are not going to be going through are things like personalized pelvic floor examination. They might not touch on a specific return to exercise plan for you. They're more than likely, won't check your abdominal wall fully. As physios, we can have a little look at your abdominal wall, but also we can use the ultrasound as well, the real-time ultrasound, to just help us with that diagnosis a little bit as well. The doctor might not have time. They might look at your scar if you've had a C-section, but again, they're slightly out of their scope of practice to advise about C-section scar massage and various different things that us physios do. So it's the medical check is obviously super important for both the mum and the baby. And as physios, we wouldn't actually see you for your physio check until you have been medically cleared by your doctor. So it absolutely does have a place, obviously, but it is very different. The check you will receive from the doctor is going to be very different to what you get when you come and see us, basically.
Jess, I don't know that normal is the right word, what's usual in regards to that you mentioned about the abdominal wall? What is usual when it comes to things like peeing and defecating and things like that? What is normal?
So pelvic floor symptom wise, we know that after both vaginal deliveries and C-section, it is really, really common to have some signs of pelvic floor dysfunction. So this could be anything from bladder urgency, leakage that comes with that, stress incontinence, so leaking when you cough and sneeze, some pelvic pain, issues emptying your bladder or your bowel, constipation. So there's lots of different things that you can experience in those first sort of 6 to 12 weeks. And it's really common too. So we do it, and even with a C-section mum, we do still expect some women to have some changes, and that's because in that time you've got all those tissues are learning how to recover and remodel. I guess the turning point here is that when you get to around kind of 6, 8, 12 weeks, if those whatever symptoms you might have, if you notice that they are just not changing and they are plateauing, but also if they are starting to get worse as well, that's where we're thinking there's probably a problem there. There could be something going on with your pelvic floor. And we would absolutely recommend that you get that checked out by physio, doctor, because some changes in the early some symptoms in the early stages, absolutely we would expect, but usually they start to get a bit better. So your bladder might feel a little bit stronger, you might feel less urgent, you might feel like you've got more support and control in your pelvic floor as those weeks progress. But in some women it doesn't, and actually that's a sign that you need to reach out for help and to get that personalized assessment to see what's going on.
Sorry, on mute. So things like that you've mentioned there, things like urgency, so rushing to go to the bathroom would be something that we would expect, but we would expect it to improve.
Yeah, so like, you know, from my experience, lots of patients might notice that they are peeing a little bit more frequently. So they're just noticing that they're emptying their bladder more than they would be kind of pre-pregnancy. They might find that they're rushing to the bathroom to pee as well. They just feel more urgent. Some women, when they cough and sneeze, might notice that they have a little leak, or if they have a belly laugh, that they feel that there's that lack of control there. You know, we know that with a vaginal delivery in particular, your pelvic floor goes under a huge amount of stress with that vaginal birth. And yeah, you're good, so that we expect some changes and some symptoms to happen. But you know, in theory, they should start to get a little bit better with time. And if they don't, that's where we have to think, okay, could there be some underlying weakness that's causing this? And yeah, that assessment would be advised at that point. The other thing also I thought I'd mention as well, from more a bowel perspective, a lot of people don't realize, but you can have it changes to your bowels as a result of pelvic floor dysfunction. If you have had a 3rd or 4th degree tear during a vaginal birth, we know that these tears are, you know, rare. They do happen, but they're not as common as your 1st and your 2nd degree tears. If you have a 3rd or a 4th, you're just at that little bit more risk of fecal issues. So bowel urgency and bowel incontinence, and that can happen in that postnatal period as well. So I've had some mums describe that feeling of just when they need to go to empty, they really need to go there and then. So those are some other symptoms to really look out for in that early postnatal period.
Jess, is this something that we just live with from then on? Like, how does that work if we've got these symptoms and maybe they're not getting better?
Yeah, I think it's difficult, because when you're postnatal, you've got so much to think about. You are recovering, you know, you're recovering, but also life goes on as well. You might have another toddler. You might be going back to work quite quickly. We know in Hong Kong that is the case. And all of this kind of can be put right to the back of your priority list, and that does happen with a lot of mums. They kind of live with it. Symptoms might get a little bit better, but then they still have this kind of lingering, maybe stress incontinence, and you know, maybe when they start exercising, they start doing a bit more, they notice that that leakage is just still there. It might get a little bit worse, but I think and you know, I would always say it is never too late. So you know, if you're having prolonged symptoms when you're, you know, into kind of a year postnatal or 2 years even postnatal, you can still make change at this time and achieve really good results. So it's definitely worth kind of seeking help, even if it's later down the line.
And for those who have had their birth story informed by a C-section, like you said, major abdominal surgery, what does that look like in terms of, you know, bladder, bowel? What are those women looking to experience? Yeah,
so we know that when, you know, if we're forgetting about mode of delivery, a pregnancy is going to be a risk factor for pelvic floor dysfunction, because you're carrying a baby for 9 months. It's a really long time to have load going down on your pelvic floor, especially if you do have a larger baby and you are a more petite woman, let's say. So even if you have a C-section, you are still at risk of some level of pelvic floor weakening or some level of dysfunction there. I guess the thing we've got to be mindful of is, you know, when you have a vaginal delivery, you're physically pushing baby out against these muscles. So there's that more physical stretch. There's a little bit of research to suggest that you're at just that little bit more increased risk of dysfunction if you have a vaginal delivery. But you know, when somebody comes into our clinic for a 6-week check, just because they've had a C-section, you know, we still ask the questions about your bladder, your bowel, and we would still offer a pelvic floor examination, because we just want to make sure we cover all bases with that.
What about the C-section scar, Jess? Are we, you know, when we talk to people in clinic, often you're not given a lot of information about what is quite a large, large scar.
Yeah, I think this is a really tricky one, because it's for such a like routine operation. It's such a big operation, and you can be left with lifelong effects and changes, and a scar that is literally going to be with you for the rest of your life, but yet you're not told about how to manage it, or you know, how to optimize it. I think that's the best word to use here, is that a scar is a scar, and it might not really give you any problems, but actually as physios, there's so much more that we can offer to help you optimize your scar to get it to the best that it can be. And, you know, like I said, the doctor, and maybe in the early stages, might assess the wound to make sure that there's no signs of infection and that it's healing nicely. But then that's kind of it. That's all you're told. And then, yeah, you're kind of left to crack on with things. And yeah, there's lots that we can do to help you with that. So scar massage is a big part of that. And you can start that from around sort of 6 to 8 weeks postnatal. If you have had an assessment from a physio, they can just give you more specific advice about what type of techniques to use. And then the other thing as well, which is really useful, which a lot of people don't know about, is silicone treatment as well. So silicone straps can be used for scars that are taking a little bit of time to heal. So kind of abnormal scars like hypertrophic scars or keloid scars. You might have heard more of the word keloid. And these scars actually account for up to 60% of scars, C-section scars. So loads and loads of women have them. And they're scars that are red, thick, and quite raised, and they can be really itchy, tingly, and sore. And actually the silicone treatment is now considered gold standard treatment for these type of scars over scar massage. So if somebody's coming in and they've got this type of scar, we really want to make sure that they are well hydrated, they're massaging, but more importantly, they are using silicone, because that's what the research says works really nicely to sort of flatten the scar, hydrate it, and promote its healing.
Jess, so is it like a bandage? What does that mean, the silicone?
So it's basically, there's lots of different ones that you can use out there. The doctors in Hong Kong actually do give you some silicone kind of on discharge when they look at your scar. And it's basically like a strap or a piece of tape that contains medical grade silicone in. And the idea is that you put it onto your scar and you cover the scar with this tape, and it really locks in the moisture, so it keeps the scar really well hydrated, along with a little bit of compression from the strap itself. It can just help hydrate it, like I said earlier, lock in the moisture, and yeah, promote its healing. So they can be really good. And yeah, we've done lots of digging at Evolve in terms of trying to find a really good user-friendly strap for mums to use. And like I said, there's different ones out there, but the one that we are trialing out at the moment and recommending is the Scar Band. And we really like this one because it comes with a little pre-cut kidney bean band shape, so it's really, super easy for the mums to use. They can use it up to 23 hours a day, and it's reusable, so you use a wash. So it's a great thing to try.
And you could you're a physiotherapist or a doctor would be able to help you with doing that, right?
Absolutely.
Jess, what about things that we hear about, the scar adherence? You hear that quite a little bit, like it affecting further on different things in your movement stuff.
Yeah, so I think that that's the key thing here, is that like a scar is not only surface deep. There's so much more that happens with a C-section scar, because we have to remember that the surgeon goes in 7 layers deep. So, your fascia is affected, muscle function is affected, And the scar tissue can really spread out all the way around the scar up into your rib cage, your hip flexors, your hip bones, down towards your pelvic floor as well. So the scar tissue, you'll have a lot more scar tissue basically than you think that you do. And scar tissue is tight, it's thick, and if it attaches onto your pelvis, near towards your back, can cause a huge amount of restriction in your pelvic mobility, your hip mobility. So if you're somebody that's super active, loves exercise, wants to hike, wants to run, if you've got deep scar tissue that's sticking onto other structures in your pelvis, it's going to be you're going to notice that. You'll notice that you're more tight and lacking flexibility there. So it can really, affect your ability to exercise in that postnatal period. But equally also in later life, like you said, Charlene, it can, if you don't treat a scar and optimize it effectively, there is risk that the adhesions can cause some issues in later life, similar to like I said, like with the restriction and just feeling like you can't mobilize as well when you exercise.
And all of that is part of a physiotherapy journey?
Yeah, absolutely. So as physios, we are trained to be able to assess your scar that is obviously unique to you, advise you how to optimize it, whether that is scar massage, whether that is the silicone straps. We also look at your movement, your mobility, how your core function works in relation to that. Basically guide you back to exercise appropriately, but obviously taking into consideration your scar and the journey that you're on with that scar as well.
Right. And I guess moving on a little bit from the scar, what about diastasis? This is like, I think my Instagram feed at the moment, it's lots of women wearing all body suits of muscles with the split down the middle.
Yeah. It's very trendy at the moment. Absolutely. Everyone's talking about it. But I think it's the focus, I guess, starting with what it is. Every pregnant woman will experience diastasis recti in their third trimester. So there's absolutely no avoiding it. The difference is when you are postnatal, we would expect some level of recovery and some level of retraction with the muscle, the abdominal wall. And the most amount of change happens in 0 to 12 weeks. So in that time frame, we can, as physios and working with the client, we can try and make the most objective change there. What that means is after 12 weeks, it doesn't mean you can't make any change. Absolutely, you can work with a physio to improve the function of your tummy and your muscles, and to achieve your goals. But just in terms of objectively, as physios, we're working towards more improving your function as opposed to closing the gap completely. That should really be the priority as physios, and we obviously make sure that we communicate that and work with the patient so that they're on the same page with that as well.
What does that look like practically? What sort of things are we doing to get that done?
So I guess if we're thinking about the early stages, so 0 to 12 weeks, that really crucial time, coming in, seeing a physio at 6 weeks is great, because there we can assess your abdominal wall. We look at your breathing, just to make sure you're breathing correctly and that you're not gripping in any area of your abdominal wall. And here we can give you personalized exercise, so you can start exercising from that sort of 6 weeks with us and work with us really closely week by week to help progress each exercise, each kind of foundation. You should start to see some change pretty quickly in that time if you're consistent and you've had that personalized approach there. Okay,
well, let's go back to this 6-week check. So I have my physiotherapist, and they say they're going to do a pelvic floor assessment on me. Now, given that I've just had a baby, I might be a little bit nervous about anyone going near my pelvic floor, cesarean or vaginal birth. Can you explain a little bit more about what it looks like?
Yeah, I think Absolutely. A lot of mums don't expect that when they come in for a 6-week check. They don't expect a pelvic floor examination. Some do, but a lot of women don't. So it can feel definitely a bit daunting, especially as you feel like, yeah, your dignity's been thrown around for all pregnancy and all of your birth. But basically, the bottom line is a pelvic floor examination is not. It is not. You don't have to have a pelvic floor examination. Absolutely, it is. Will always be up to the patient whether they want to have it or not. But basically, what it is it's a really useful way that physiotherapists can assess your pelvic floor function and to give you the most up-to-date and personalized program for your postpartum rehab journey. So what it involves is it's non-invasive, not painful, and in some cases can take less than a couple of minutes. It's really, really quick. So if you think about your smear tests and your gynae appointments, where they're using speculums and ultrasounds and all of this, we don't use any instruments or any equipment. So it is really, really gentle. And we would always explain in a huge amount of detail before the examination happens what the clinical need for it is, first off, and then how we would do it in each step, just to make sure that you are happy. And then if you consent, we do it. And if you don't consent, we don't do it. And that's absolutely fine as well. So basically, like I said, what it involves is a really quick examination externally first of your vulva. So just looking to see if you have had any perineal stitches. What does that look like? How's the healing process gone? You should have had them checked anyway by your doctor, but we again just like to look again just to make sure everything is healing nicely. If you've had an episiotomy, which is that surgical incision out to 8 o'clock, we would look at that as well for you, just to give you a bit of advice about that. Then if you're all fine and we've kind of checked everything over externally, we then do the internal part of the examination. And like I said, no instruments. We would literally use either a finger or two with a glove, with a little bit of lubricant, starting just at the entrance of your vagina and then taking it step by step, looking at the external tissues and then kind of working very, very gently, a little bit more internally, just to assess if there was any pain anywhere. What do the muscles feel like? Are they nice and relaxed, or are they on the tighter side? And then the last thing we do is we get you to do a bit of functional stuff. So we get you to squeeze and we teach you how to do your pelvic floor exercises effectively. We look at some quick ones and then some longer holds, and we do some other bits and pieces there as well. And then that's it. And then afterwards we sit and talk about it and we explain our findings to you and link it back to your symptoms. So if you're symptomatic, we might explain why some of your symptoms are happening for X, Y, and Z reasons because of the pelvic floor assessment. And that's it. So yeah, it is a very quick and simple examination. And often women afterwards will be like, oh, was that it? So we make it as kind of as comfortable for you as possible. And like I said at the beginning, if you don't want to do it, you don't want to do it. There's other ways that we can assess things as well.
In your experience, what are some of the outcomes that you get from that pelvic floor, like, for clients?
So if somebody's had an episiotomy, let's say, for an example, and it's a slightly more, we call them extended episiotomies, where the OB's just gone, it's a slightly longer incision, basically. Instead of it being quite small, it's more like an inch or two. Sometimes they can be quite tricky to heal because they're a little bit thicker. They come out into the butt cheek a little bit more. So if we can give you some advice about how to massage that tension away. So that's an example of an outcome. Also, we can diagnose a prolapse, a pelvic organ prolapse, which we can kind of do that at 6 weeks plus. And again, a doctor should be able to do this as well. But as physiotherapists, we see them a lot, so we do have a lot of experience in kind of treating and assessing pelvic organ prolapses. So we can give you that assessment there and kind of give you some advice about that. And then I guess just, lastly, looking at your function of your pelvic floor. So we grade your strength on a little scale from 0 to 5. So we give you a magic number, tell you where you're at. And then we might look at your endurance, your coordination, just to assess the function of your pelvic floor, see what's really good, and then see what components maybe you need to work on. And then, we give you a personalized program with that. So that might be pelvic floor exercises, but it also might not be. It might be stretches and some breathing. So it will really depend on how you present and what we find.
How does breathing work into that? I'm confused with.
When we talk about Kegels all the time and kind of strengthening your pelvic floor, but in a lot of women, we know that we actually find that the muscles down there are too tight and in a kind of contracted state, which is not ideal, because a muscle should be able to relax fully and then contract fully. So if it's on the tighter side, that can cause some problems, and that's something that we can pick up on really quickly during a pelvic floor examination. So that's kind of where physios, we can be quite good at that, picking up something quite niche. And if somebody's pelvic floor is a little bit on the tighter side, we would want to assess their breathing, because we know that when the pelvic floor is quite tight, the diaphragm, which is the muscle that controls breathing, also tends to lack mobility as well. So when we teach somebody how to diaphragmatic belly breathe and really use that diaphragm, we notice that actually the pelvic floor muscles along and can drop and let go and relax with that. So it's a really interesting way to kind of assess whether somebody's pelvic floor is too tight, and it's a treatment option as well. We give them breathing to help relax off the pelvic floor.
That's awesome. So talk about not knowing which end to work with. Jess, once we are through the 6-week check, perhaps we're feeling good or feeling ready, or maybe not, what does return to activity look like?
So it's a minefield. There's so much information out there about returning to exercise, and lots of different clinicians will give you maybe similar but also different answers. And I think what it comes down to is, again, it is such an individual thing, and every woman will return to exercise at a different time, and that's okay. There is guidance, absolutely. So as physiotherapists, we have a set of guidelines that we should be referring to when we rehab somebody back to exercise. So we know that if we even think before the 6-week check, so kind of week 0 to 6, there's definitely things that you can be doing in and around the bed to get your body ready and your body moving again. So, and we can give you that advice when you're pregnant. So when you're late trimester, give you a little bit of advice about what you can do in that time before you come and see us at the 6 weeks. So breathing, gentle exercises in the bed, hip and pelvic mobility exercises, some stretches, and some light body weight exercises you can do around that time. When you see us at 6 weeks, that's when most people are, from what they hear, is that you're given the green light to kind of exercise. So absolutely, at this point, most mums are feeling ready to start to potentially add some resistance to their exercise. So they might, use some lighter dumbbells. And if they've had an assessment and they feel it and everything is coping well, they absolutely can. So even things like, yoga, Pilates, some light resistance training, some swimming and walking, progressing your walking, a bit of hiking is good. At this point in time, I think if somebody's goals, let's say, are to get back to running, the guidance says that 12 weeks is usually when you should kind of start that process. But as a physio, what we can do is actually, when you're kind of weeks 6 to 12, is we want to test the waters with load and actually see how is the body going to cope when we introduce a little bit of impact. So yeah, we can test that out for you, is get you, start doing some star jumps, some lateral bounds, some jump squats, just to see how your core and your pelvic floor copes with that load. And then once you're around that 12-week mark, that's when we can start introducing proper impact. So yeah, interval-based running, let's say, if we're using running as an example. I think, yeah, so those are the guidelines. We know that every mum is different, so it might be that if, let's say, a lady's been assessed by a physio and actually she's ready at 10 weeks, then she's ready at 10 weeks. Everyone will be different, but so it's just, the guidance is just guidance, basically.
What should I be looking out for if I'm returning to exercise? What are the things that sort of should be a flag to say, just hang on a second?
Yeah, I think probably the most obvious one is any type of pain. So if you're especially pain in your pelvic floor, so if you're feeling anything externally down below, or even in your pelvis, if you feel like near around your bladder, your bowel, any sharp or shooting pain or any dull achiness as well, can be a sign that something is going on, just something to look out for. The other thing as well is pelvic, like urinary symptoms, again, can be quite an obvious one. So if you start to notice that you are leaking when you're running, let's say, or even leaking when you stop exercise. So when you're running and then you then stop and then you leak, that can be a bit of a warning sign there. And then, yeah, I think those are the main ones that we kind of tend to think about. I guess also if you're noticing that you're becoming injured quite quickly with exercise, if you're in that postnatal period and you're getting an ankle injury, a hip injury, that can be a sign that actually has your whole system been properly rehabbed. Because if you're getting other symptoms in other joints, it usually means that there's an issue with, maybe, let's say, with stability of the pelvis. So kind of injury is another sign.
So it really is the first step, the basis for after birth. We heal and then we prepare.
Yeah.
That pelvic floor preparation really is key for injury prevention all the way through.
Yeah, and yeah, even like up until a year postnatal, 2 years postnatal, you're still in that remodeling phase, that time. So yeah, I think it's important that you get the foundations in place before you start to load your body again. And yeah, it's difficult because you're mentally, you might be feeling so more than ready to get going, and to, especially if you really need it for your mental health, and that is really difficult to deal with. But your pelvic floor might not be ready. And I always say to my patients, I'd much rather hold off and rehab you properly than give you the green light and then you come back to me and say you've got an injury, or you're leaking, or you've got heaviness, let's say, and then I have to go, sorry, we can't do that for the next few weeks. So it's like dangling the carrot and then taking it away again. So yeah, I'd always say it's better to kind of be as patient as you can with it.
Jess, can you I'd love to hear some anecdotes of clients returning to exercise and things like that. What type of things do you see in clinic?
Do you mean in terms of like things that come up yeah. I think, like some women do experience a bit of I think heaviness is probably, and I'm sure my colleagues will agree with me on this, that some vaginal heaviness is something that a lot of women experience when they return to running or some weight training. And heaviness is typically can be a symptom of a prolapse. But just because you have heaviness does not mean that you have a prolapse. We don't want you to stress yourself out about that. It's just a sign that potentially there's some fatigue in your pelvic floor, and perhaps the endurance and the strength is lacking a little bit. So again, that's where an assessment can be really useful, so that we can work on that together. So yeah, heaviness is definitely one. And then, yeah, returning leakage as well, kind of, like we said, either during a run, post run, can definitely is something that we see a lot of, but obviously not normal. Important thing to remember.
Yeah. And something can be done about it.
Yeah, something can be done. And it does also, the important thing I always say is, like, just because you're leaking during running, it doesn't mean that then that's it, you need to stop running. It, you know, we modify. That's how we do things. We reassess, reevaluate what's going on, and modify your program or your training so that then you don't leak. It doesn't necessarily mean that that's the end of the game for you. It just means that things might look slightly different for the next few weeks, let's say.
I think that's really hard when you're in that stage of just having had a baby, isn't it? Like, that everything feels like this is it, this is my life. The baby is never going to sleep. The baby, you know, this is it. But things do change. Yeah. And by having a good team in your corner, physiotherapy, OBGYN, whatever that looks like for you, following good guidance and listening to your own body, things can change and do.
Yeah, absolutely. I think that the majority of the time, your body is a really clever thing. Like, remodeling occurs, and remodeling can take up to 12 to even 24 months. So we do, you know, a lot of women, the vast majority of the time, would say that they do get better, just kind of naturally with time. But then, yeah, it's then making sure you're not falling into the trap of having a random symptom and then just being like, okay, this is what I'm going to have now for the rest of my life, because there's still so much work that can be done in that time, in that postnatal period.
Jess, I mean, we could go on for hours. Literally, we could go on for hours about the postnatal journey. Everyone will receive the link to this video, which will have your details on it. And we welcome, obviously, people to drop you a line, to have a chat, just to touch base, and obviously come in or find a women's health physiotherapist that suits you. Jess, I do want to touch just on one thing, because we're in this postnatal journey, and if people, what about things like breastfeeding and things like that? I know it's a whole different Lunch and Learn series that we'll do, but just tell me a little bit about breastfeeding and some of the things that come up with that. Yeah,
so I think from two things that to think about here. Number one, when you breastfeed, typically you have a little bit lower estrogen, which is that strength hormone that gives us lots of plumpness and strength and integrity to our tissues. So when we breastfeed, that natural level just sits a little bit lower, and this can really impact your pelvic floor and how your body feels in that time, and your kind of your healing process as well. So I always say to my patients that it's not a reason for you to give up breastfeeding altogether and just be like, right, I'll throw the towel in and then things should get a bit better. But it's just something to be mindful of, that when you do breastfeed, you know, healing might take that little bit longer, and it's just giving yourself some grace and some time there. The second thing, I guess, is from like a mastitis point of view as well, is lots of women do unfortunately develop mastitis, and we can also help you from a physio point of view here in terms of just reducing inflammation of the breast and giving you lots of advice about lymphatic drainage, massage, hand expressing. So yeah, there's physios can also help in that different area as well, and that's a whole different thing. But yeah, there's lots we can do there as well, because that's a really common thing that happens in that postnatal period as well. Just to add another thing to the pile that mums have to go through. just add it. Jess, we're gonna finish up just really soon. What is, if someone has to take one thing away from these 45 minutes with you, what is the one thing that they should try and hold? Gosh, there's loads, but no, I think the one thing for me, and it's something that I'll always stand by, from a kind of pelvic health point of view, because I've worked with lots of women from pregnancy, postpartum, and then into their 80s. I think the thing to remember is that it's not you've still got so much time to make change, and it can take up to 7 years for women to speak up about pelvic floor issues and women's health issues, which is crazy. And that's for various different reasons. There's so many barriers as to why that is the case. But yeah, that's probably my main thing, is that it is never too late. So don't just think because you are a year postnatal or 2 years postnatal that's it. You know, you can still make change. You just need the right guidance. And yeah, I think if you don't do anything, nothing changes. That's probably what I would say as well.
Amazing.
Right.
Amazing. Thank you so much, Jess, for your time. Thank you, everyone, for joining the call. We'll be sending out the link to the YouTube channel where this will be housed. But again, please reach out. This is part of our effort to provide free education to science-based and evidence-informed pre- and postnatal care in Hong Kong. So please do reach out and forward it to any friends that you think that might benefit as well. So thank you very much, everyone. Enjoy the rest of your afternoon. Stay dry in this rainy Hong Kong weather, and we'll see you all again soon.
Yes, thanks, Janine. Thanks, everyone.